Hey, UnConference crew. Dave Walton here. Sorry I couldn't be with you in Toronto this weekend. I'll be perfectly honest, I am a little travel and conferenced out, which sounds like a bit of a cop-out. It is actually currently 20 after 11 at night on Friday night, the night before this event. I'm just getting back from Boston, from the North American Spine Society. I still have a 2.5-hour drive home, and seeing the phenomenal lineup that the organizers of this UnConference have put together for you, there's no real need for me to be there. You're in fantastic hands. I'm sure better than if I was there, and I just have to give a quick thumbs up to the Pain Science Division for taking this risk, for being willing to disrupt the traditional conference model. It's well past time. And as I say, I just came from the North American Spine Society conference, massive conference, but yet again a big conference of bums in seats, and people shuffle in. A few brave souls may ask a question after listening to us talking heads for a couple of hours, and everyone shuffles out again. And I'm not really sure that any transformative learning has occurred. A good UnConference, such as the one that you're at now, we really hope that it's going to lead to some transformative change in your clinical behaviors, and of course, at the end of the day, better patient outcomes. So good work to you for being willing to participate in this inaugural event. And as I say, 2 big thumbs up for the Pain Science Division and the organizing committee for putting this together. Despite my not being there, I was asked to address a couple of the questions that you submitted, and so I'm going to do that now. I've got my laptop here in front of me, and I'm just going to go through them. I'm not going to answer all of these because, again, I think the people that you've got sitting there today are probably going to do at least as good, as, if not a better job than I will in answering some of these. I see one question here. The question is, I'd love to talk about some strategies to discuss prognostic timelines, especially for those with persistent pain. It can be challenging to predict how long it will take for them to really notice improvement. The only reason I wanted to mention this, for one, because I love to predict the future, but for two, this is a really nice opportunity to plug the photo system. For those of you who aren't using it yet, that's the Focus on Therapeutic Outcomes system. You may or may not know that CPA is subsidizing this system this year. You can get it in your clinics for dirt cheap, and Photo does exactly that. Through a machine learning process and big data methods, it will... It'll have your patients complete a series of questions, and then afterwards give you a frighteningly accurate estimated trajectory of their recovery. So I would encourage the person who asked that question to look into Photo if you're not already. So I've got, another one here. How do you use screening tools such as the pain catastrophizing scale or the Tampa scale for kinesiophobia to inform the content of pain education? Now, again, I know you've got an expert, or at least a couple of experts on pain education in front of you. I just wanted to highlight this one in as much as glad to see people are considering the use of these tools. I will say do so with intent and judiciously. What I mean by that is don't just sort of willy-nilly toss them out to all your patients without having a good game plan in mind. Know what the scores mean, know how to interpret those, and have a follow-up plan. If you see high scores, and again the TSK less so, but the PCS definitely has some reasonably well-established high scores. 20, 24, and 30 are the cut points that are sort of in literature these days. So if you're going to use those as part of your treatment plan, I'm more of a fan of looking at the individual item responses rather than just the summed score. Looking at how people respond to each individual item can open up some really interesting lines of communication, and that can become the basis for your education at times. Hold on, I'm just quickly zipping through some of these here. This is an interesting one here. I'm finding it challenging not to ask the clients about their pain during our active treatment sessions. Do you have any strategies to help the clinician feel more comfortable on taking the focus off the discussion of their pain? I'm going to mention this one, and I suspect that the people there, the experts there today, have some additional comments here. I'm not entirely convinced that not talking about pain is actually the right way to go. I know that was sort of a thrust for a little while. As Mick Sullivan will tell you, that someone who happens to be a high pain catastrophizer, if you don't acknowledge that they're experiencing pain, they'll probably turn the volume up. So I think the skill really here is more acknowledging that the person has pain, and if I can use a Hillary Clintonism, maybe then pivot to talking about function and what they're able to do despite their pain. But I know a couple of clinicians in the past have said, "Oh, I'd never use the word pain in my clinical practice," and that feels like it's sort of an unnecessary game to play in my mind. It'd be like if I went to my doctor and I said I had the flu, and the doctor said to me, "Okay, I'm going to tell you all about your condition today, but I'm going to try and do it without using the word flu." All right. So, I'm not entirely convinced that that's the right strategy. And then there's one here, and boy, this looks right up my alley, as though somebody may have written it for me. The role of HPA dysregulation, so hypothalamic pituitary adrenal axis dysregulation in pain, and the role of the microbiome in pain. Wow. Okay. So I guess I'll address each of these really quickly. As far as HPA dysregulation in pain, so the primary outcome of the hypothalamic pituitary adrenal axis would be the release of cortisol, which is our primary stress hormone in our body. And if you look up the effects of too much cortisol, so hypercortisolism for too long, you'll notice that they look a lot like chronic pain. So it'd be widespread bodily pain, muscle catabolism, cognitive interference, digestive problems, sleep problems, that kind of thing. Boy, that sounds a lot like chronic pain, and there's a bit too much overlap there for me to ignore that. The person who wrote this, I don't know, may know that we're doing this work, and we continue to find that there's an association, at least a linear cross-sectional association, and possibly a longitudinal association between cortisol, and we measure that both in saliva. We actually measure it in blood as well to make sure we're getting the same thing. And we take hair. The wonderful thing about hair is that cortisol is stored there. So if we assume your hair grows at 1 centimeter per month, we can take your hair, and depending on how long it is, we can go back in time prior to your injury, and we can get then a sense of whether, if we're seeing high cortisol levels in your saliva right now, is that just because you happen to be a high cortisol person, perhaps genetically or just through some personality trait or sort of stressors in your life, or is this a result of the trauma? And so being able to go back in time is sort of become a bit of a game changer for us. And just again, we do see some nice relationships between things like pain catastrophizing, pain intensity, and things like the cortisol waking response. Which is a nice little proxy of what's happening with that HPA axis. And then there's the question of the microbiome in pain, and I have to say that this is brand new. In fact, I would love to know who asked this question and where you came up with it, because again, big thumbs up to you. I will say that there probably is a role at this point. The gut-brain axis is a thing. The microbiome in our gut communicates with our brain and vice versa. And there's not been a ton of work done, to be honest, in the field. We in my lab at Western University currently have a freezer full of human adult poo, which I never thought I would have as a physiotherapist, and I just cross my fingers every day that the power doesn't go out in my lab, because that would be nasty. We expect we're going to see something. We don't know what that something is yet. We're following the microbiome longitudinally over the course of a year following a traumatic injury. Based on work in other fields, we would expect that the diversity of certain bacterial flora, or bacterial families, I should say, are probably going to reduce. So you won't have as diverse a gut flora as people who are maybe otherwise in well health. And of course that opens up interesting conversations around how could we manage that, and probably the least gross of those would be to use probiotics. The most gross of those would be to do fecal transplants. So The answer to that question, I'd say, is stay tuned. It's certainly a burgeoning area in a lot of different fields. We've got more bacteria in our bodies than we have cells. So there's something going on there. So those are my answers to your questions. If you have any others, or if anyone needs to contact me, you can certainly do so. My email address is dwalton5, that's DWALTON5 at uwo.ca. And anyway, enjoy the rest of your weekend. Jeez, I hope I'm not getting kicked out of my parking spot. Ciao.